Good afternoon, St. Louis. Welcome to the second segment of the City of St. Louis Department of Health's Truth Series. The title of today's presentation will be The Truth About HIV/AIDS, What People Really Need to Know. In the City of St. Louis and across the nation, HIV and AIDS continues to disproportionately impact the lives of residents and visitors. And one of the things that is perpetuating the disproportionate, disparate health outcomes associated with HIV is misinformation. And so the City of St. Louis Department of Health aims to make sure community members and stakeholders across the region have access to accurate information regarding public health issues. So today we have a special guest with us tonight, Dr. Mati Lachweo-Davis, an infectious disease physician from that practices at Washington University School of Medicine, as well as at the Veteran Affairs Hospital here in St. Louis. Again, she's an infectious disease physician whose expertise is in making sure individuals living with HIV have access to quality healthcare services and support services. She's an advocate for public health, as well as an advocate for the community at large, especially our most vulnerable populations. And so we're really grateful to have her with us tonight. And at this time, I'm going to turn it over to Dr. Mati Lachweo-Davis.
Thank you so much, Dr. Eccles, for having me. And thank you to all our attendees here today. I don't take it lightly that after a long day of work for most of you, or wrangling the kids for some of you, or just really continuing to deal with our current pandemic, that you would join us here today. It shows your dedication to learning as well as to supporting our brothers and sisters living with HIV. So today I will be giving a short talk about HIV and stigma, the path forward, and after which we will open up for questions or discussion points for us to really dive into this topic. So just starting off with a little bit about me, just to reassure you that I have reason to be here in this capacity this evening. As Dr. Eccles said, my name is Mati Fadza, but just Mati Lachweo-Davis. And I am on faculty at both the Washington University School of Medicine and the John Cochrane VA Medical Center. So starting at the Washington University School of Medicine, I see patients both in the hospital and in the clinic. I am on the leadership of the Office of Inclusion and Diversity, and my areas of interest with research are around HIV, most recently COVID, community engagement, and marginalized populations. At the VA hospital, I am the lead HIV clinician. I am in charge of graduate medical education, so all of the training of our fellows, and I also oversee all the outpatient antibiotics. So anyone who has to go home with antibiotics through an IV is someone that I oversee those situations. But more importantly, I'm also a mother to Naniso and Aneni. Naniso is our newest member of the family at 6 months, and her older sister, Aneni, 4 years old. I am a wife to Jesse Davis, Dr. Jesse Davis, let me not diminish him, who is a pediatrician, specifically a hospitalist in the NICU at Children's Hospital. And I come to you humbly, wearing all of those hats this evening. So what are our objectives for this evening? What do we hope to accomplish by the end of this talk? Well, three main things that I hope that we will all walk away with today. Number one, I'd like to be able to provide you with a history of HIV tonight. I also would like to address stigma and the reasons behind it. And lastly, I want to be able to discuss a path forward with you. What do we need to do to better support this community who really are the people around us, the people that we care about, and the people that we should be advocating for? So before we get started, I think it's important to understand a few definitions and statistics to give us the lay of the land of where we are right now and what it is I am talking about. So number one, what does HIV stand for? Well, HIV stands for the human immunodeficiency virus. It is the virus that can lead to AIDS, which stands for acquired immunodeficiency syndrome, if not treated. So HIV can lead to AIDS if it is not treated. You need to think of these two words as operating on a spectrum, and you can get to AIDS if you do not treat HIV. HIV attacks the body's immune system, and like I said, left untreated, it progressively weakens the immune system, making the person more likely to get other infections or infection-related cancers. And over time, it can destroy so many of these cells in our immune system that the body cannot fight off infections any longer. And this will then signal the diseases that lead to AIDS, which is the last stage. So to look at a few statistics here, a few numbers to give us an idea of how this is impacting our country at the moment, and then I'll talk specifically about our region. Of the almost 38,000 new diagnoses in the United States and dependent areas in 2018, 69% were among gay, bisexual, and other men who have sex with men. 24% were among people who identify as heterosexual. And then 7% were among people who inject drugs. But what about closer to home? So these are some busy slides, and I want you to bear with me and let me lead you through these so that you can understand what it is we are looking at. So on the left are some charts, and we're going to talk about who is living with HIV in Missouri from a gender perspective, right? So we have total, we have female in the middle, and then we have male. And the colors that we're looking at are of the 13,000 people who are living with HIV in Missouri in 2018, overwhelmingly most of those were men. And that's not surprising if you're paying attention to the slide before, where I told you that 70% of people living with HIV are accounted for by people who identify as men who sleep with other men or transsexual. And then there's all these colors, and I will lead you through these colors one at a time. So of all the people living with HIV in Missouri in 2018, 85% of those were linked to care, meaning were able to find a provider and to connect with a provider so that they could get care within 90 days. So that's within 3 months. Of those, 72% were the orange. They were able to be linked to care within 30 days, so within 1 month. We need to see that as close to 100% as possible. After that, of all the people that were able to get a provider, only 44% stayed in care. 44% went from that 85% where they were able to connect with someone. It took a while, right? It took 3 months. But of those, only 44% were able to be retained in care. That's a problem. Why is it that people living with HIV, once they find a physician, find somewhere that they can get care, don't stay in care? That's a failure of the system, right? And that's something we need to pay close attention to. So then we get to the purple and the blue. Well, of those 44% that were retained in care, only 38% were virally suppressed, meaning that they were taking their medications but weren't taking it as prescribed, which is every day, to be able to keep the virus from being active in their body. They will always, unfortunately, have HIV in their body, but only 38% were taking their meds such that we could not draw our blood and be able to detect it in their blood. That is a major, major failure of the healthcare system. So I have these graphs, as you can see. The next one is by age, right? And of the people living with HIV in Missouri in 2018, 484 were in the 13 to 24 years old group, almost 5,000 in the 25 to 44, and over 7,000 in the 45 plus. I'm telling you, if this were the 80s, this would look very different. This is showing how well we have done with our medications to this point. in that we are seeing people live much longer with this disease. But as you can see, the same pattern where once they found a doctor, they weren't staying in care, right? And then they weren't able to take their medications such that they were living healthy lives. This is an issue with the system. And I will make an argument tonight that a lot of that has to do with stigma. So let's talk about race and ethnicity. So again, we're looking at 2018 data in the state. Overwhelmingly, most of the people living with HIV in our state of Missouri identify as Black or African American, with over 6,000 people. After that, we have 6,100, about the same number of Caucasians. But remember, African Americans make a much lower proportion of the overall population. So this is really a staggering number in the Black community. And then 616 Hispanic. And some of that, again, you have to identify as being reflective of the overall race and ethnicity of the state, right? And then lastly, we saw, again, similar to what we saw on my initial slide reflecting the whole country, 8,000 men who have sex, over 8,000 men who have sex with men, almost 2,000 heterosexual, and then 674 people who inject drugs. But really what I want you to pay attention to in these last two slides is that we have a real problem having people stay in care once they're in care and then having them on their medications. So let's discuss a little bit about how you can get HIV. Why did I even include this slide? I'm sure a lot of you now know this information, but it's for the very reason that this slide alone is one of the main reasons that we have an issue with people discriminating against people living with HIV, living in fear of them, and wanting to stay away from them because of the perception that they, just by being around them, just by touching them, can transmit HIV, which is an absolute lie, a complete fabrication and a fallacy that we need to get rid of. So how can you get HIV? You can get HIV through two main ways. It must cross a mucosal membrane, right? A membrane that is covered in a mucosal layer, or be injected into the bloodstream. So the ways that are listed in green here are through blood, through semen, through pre-seminal fluid, through rectal fluids, through vaginal fluids, and through breast milk. Now let's talk about how you cannot get HIV, because if it's not on the box on the left, it's not happening. So you cannot get it through air or water, not through saliva, certainly not through sweat or tears, not through closed mouth kissing, unless you have a cut and a barrier that goes through, again, that mucosal layer, not from insects or pets, and not from sharing toilets or food or sheets, right? Not through sitting next to someone or hugging them, not from sharing the same spoon. This is not how you get HIV. And I know that this is something that is very hard for people who have heard about this from long ago, from the 80s and 90s, when we didn't have as much information. But these are the facts, ladies and gentlemen. This slide alone is one of the main reasons that my patients live in fear, live in secrecy, and do not trust that they can share their diagnosis with their loved ones. So let's talk about a little bit of history here. So this slide that I have before you is the very first newspaper article that spoke about HIV in 1981. Back then, there was an unknown epidemic spreading across America. In June of that year, the CDC reported 5 cases of a strange pneumonia in Los Angeles. By July, we had 40 cases of a rare skin cancer in the gay communities of New York and San Francisco. And then by August of 1981, there were 2 rare diseases. The first was a skin cancer known as Kaposi's sarcoma. And then the second was this rare pneumonia caused by pneumocystis, which is a form of pneumonia caused by a parasitic organism that had infected over 100 gay men, killing over half of them. By the end of 1981, we had 121 men who died from this strange disease. So what did we see back then? Well, suddenly a large number of people were dying from this pneumocystis pneumonia and that cancer, the Kaposi's sarcoma I was talking about, and this was attributed to AIDS. A year after scientists identified AIDS, they discovered the cause as HIV, this virus. The media started calling the main groups of people who seemed to affect the 4H club: homosexual men, hemophiliacs, heroin users or people who inject drugs, and Haitians, the 4H club. If people got AIDS, they died. That's what we knew. It took approximately 10 years from the time of infection to developing AIDS, but typically people were dead within months to 2 years of diagnosis. And you were seeing all of these really, really debilitating pictures and family members that were dying from this horribly debilitating disease. This took the media by storm. So in 1982, we'd given it a name. By 1984, 2 different scientists had isolated the virus causing it. And by 86, that virus was named HIV. But by the end of the decade in 1989, almost 30,000 people had died from AIDS, and we still didn't know how to stop it. Oh, this caused a flurry of activity. We had researchers trying to do the best that they could to get ahead of this. We had activists from the gay community marching and protesting to be seen and heard. We had the media printing pictures, and this was on the cover of Time and every major media outlet. This became a political issue with the current conservative government, right? And then we saw different communities react to this in the way that they knew how, right? If you look at the top right-hand corner of this slide, some of the titles from the newspaper: "Is this the wrath of God?" asked Bible thumpers. Why even doctors dread this killer, right? The peril. I mean, this was a highly sensationalized topic, and for good reason. People were dying and we just didn't know what to do. I wonder how many of you know what movie this is. One of my favorite actors, at least. It had taken over the media and even Hollywood now. Philadelphia, released in 1993, was one of the first mainstream Hollywood films to acknowledge HIV/AIDS, homosexualities, and homophobia. Stigma started way back then. Tom Hanks won an Oscar for his role here, right? As a lawyer who hid his homosexuality and exhibited signs of that cancer I was telling you about, the Kaposi's sarcoma, and sued his firm for discrimination after they fired him shortly thereafter. The scenes were very compelling. We see his body change as he fights for what he deserves. These images walk us through the dramatic changes that untreated HIV and consequent AIDS can cause on the human body. So this is a graph I want to walk you through that just really depicts how very serious HIV was starting from 1982. Until then, if you ignore the red curve, the number one killer of folks in the 25 to 44 year age group was unintentional injury, followed by cancer, heart disease, suicide, homicide, chronic liver disease, stroke, and diabetes. All things that were, much to this day, these switch out 1 or 2 and have changed over time. But you can tell that they're pretty steady over time, right? The lines are straight. They go across the stream. And then in 1982, HIV hit the scene. And do you see this exponential increase until it became the number one killer of folks in the 25 to 44 year age group in 1992 and 1993. But then something happened in 1995 or thereabouts. And you see this dramatic decrease as it started to plummet. And I wonder if any of you know what that is. Well, I'll tell you. Antiretroviral therapy. We got a drug, finally. AZT came to save the day. And it was introduced in 1987 as the first treatment for HIV. Scientists also developed treatments to reduce mother-to-child transmission, but it wasn't until 1997 when we had highly active antiretroviral therapy became the new treatment standard. And that's when we started to see an impact, causing 47% decline in death rates. AZT was the first glimmer of hope of a drug that we had back then. And it slowed things down, caused tremendous optimism. But this was short-lived. because it was toxic. Much like chemotherapy drugs are necessary for cancer, but in themselves can be very toxic to the body. We saw that. This picture that I have on the screen shows you how back then, back in 1997 and in the late 90s, that's how many folks one person was taking pills one person was taking in one day. We're talking 15 to 20 pills, each with its own side effect panel. These folks were suffering to save their lives. And then we come to today. 30 years ago, this was a death sentence. But now I can say that a young 25-year-old with a new HIV infection can lead a normal life expectancy if they take just one pill a day for the rest of their lives. One pill a day. This news should mean I'm out of a job. We should be able to give this pill, people take it once a day, and move on with their lives. So why do you still need specialists like me and other physicians that dedicate their lives to HIV? It's because of this terrible, terrible stigma that we have chosen to attach to this disease. And in so doing, make this such a difficult, difficult disease for us to support people living with HIV and treat them effectively. So I think it's time. Let's talk about stigma. So what is stigma? Well, HIV stigma talks about the negative attitudes and beliefs about people living with HIV. It is the prejudice that comes with labeling an individual as part of a group that is believed to be socially unacceptable. I think it's easier to talk about if we have some examples. So one example would be believing that only certain groups of people can get HIV. And that's incorrect. I've shown you data from the beginning of that. I've showed you that this has no age group that it only targets, no race that it only picks one of, right? That it affects people of all different walks of life, all ages, all subgroups. A second example would be making moral judgments about people who take steps to prevent HIV transmission. So folks who choose to empower themselves, right? So one of the biggest things I see around this is sex shaming, right? Healthy, consenting adults should be able to lead a healthy sexual life. And in so doing, there are now medicines that they can take to help prevent HIV transmission. But even then, that's shrouded in judgment and shame. And another example would be feeling that people deserve to get HIV because of their choices. That is terrible. Terrible. And while we do this in some small degree with diabetes, for example, where we'll judge people because of their lifestyle choices, we would never say that about people who have cancer or anything else. And that cannot happen with people living with HIV as well. It leads to discrimination. And what do I mean when I say that? So while stigma refers to an attitude or belief, when I talk about discrimination, I'm talking about the behaviors that result from those attitudes or beliefs. HIV discrimination is the act of treating people with HIV differently than those without HIV. So this is who I am. I'm big on examples so that we can really drive this home. So a couple of examples here. So one example would be refusing casual contact with someone living with HIV. Wrong, period. I showed you that data. I told you that people living with HIV cannot give you HIV just by touching me. Another example would be socially isolating a member of the community because they have HIV. This is the reason why my patients are so afraid to even come and see me, for fear that they may run into someone who knows them, because they're so afraid of being isolated. I'll tell you a really sad story. I have a patient who's been living with HIV for 30 years. He does everything he's supposed to. He takes his medicines, he comes to see the doctor, he has his labs drawn. He is one of the kindest, most beautiful humans I've ever met. But I am the only person outside of one family member that he tried to share that he will ever tell that he has HIV. And on top of that, he's so afraid that he refuses to have any sort of loving, intimate relationships. And this happened because he chose to share his diagnosis with his sister. And he was a proud uncle. He had 2 nieces and nephews that adored him. And when he shared with his sister, and they would come, he used to tell me stories about how he'd go to his sister's house, and one of his favorite things was to sit on the couch and make sure they didn't know he was there. And then they'd come running around the corner, as they often did, and they would start screaming at him at excitement and come sit on his lap and get hugs. Well, after he shared with his sister, she would not allow him to be around the kids. To this day, he knows of them, he sees pictures of them on Facebook, but he has never seen those children again. That is wrong. That is discrimination embedded in stigma, that's embedded in incorrect, unfactual, and unkind behavior. And a last example would be referring to people as HIVers or positives or some sort of slang that you think is easier or funny, but is not. It simply is not. It's wrong. So what I've tried to get to the bottom of here is to show that fear from incorrect information is intimately tied to these judgments we make that then cause stigma. So why do we care? How bad can stigma really be? You could be asking yourself. Well, I talked to you about the causes, right? Fear, lack of information, and outdated beliefs. But it's important for us to get to the heart of the effects. What will happen if we allow this to continue unchecked? Well, the first thing is that there are very significant emotional and mental well-being that is attached to dealing with this disease. And if we continue to have these negative and damaging interactions that are born from stigma and born from discrimination, this can negatively impact people's emotional and mental well-being. People living with HIV often internalize the stigma they experience and begin to develop a negative self-image. We call this internalized stigma. They may fear they'll be discriminated against or judged negatively if their HIV status is revealed, I beg your pardon. So internalized stigma or self-stigma happens when a person takes those negative ideas and stereotypes and start to apply them to themselves. And it can lead to feelings of shame, a fear of disclosure, like I told you about my one patient, isolating themselves, and despair. And this can lead to people avoiding getting tested and even getting treated once they know their status. So is there a path forward? Well, I truly, truly believe they do. But I'm a scientist, so I'm gonna back that up. I'm gonna back my hope and my positive energy with data. So I'm about to teach you and bring to you the U equals U campaign. And this stands for undetectable equals untransmissible. And what I mean by here is that a person living with HIV who has undetectable virus or undetectable viral load does not transmit this virus to their partners. And if you don't believe me, let me tell you why. There's research that backs this up. The first is the Swiss statement back in 2008. And what this was a group of experts who agreed, because they had data and because they had followed these patients observationally over time, that a person living with HIV with an undetectable viral load for at least 6 months and who continues to take their HIV drugs had a negligible risk of transmitting HIV. So what I mean by that is that the risk is so small or unimportant that it's not worth considering. Well, some of you are like, may not be significant to you, but it is to me. Well, I've got more data. After that came a study entitled HPTN 052. And this was where more than 1,000, mostly heterosexual mixed couples, and what I mean by mixed is one person had HIV and the other did not, joined the study. And the person who was living with HIV had a detectable viral load. So let me back up. So this was where you had two people in a couple, one with HIV, one without. And they followed these couples, right, as they had sexual contact without a condom. And they found that very few cases of HIV transmission occurred. But there was a caveat here. The person living with HIV had to be taking their medicines every day and had to have had that undetectable virus that I was talking to you about, that undetectable, meaning we draw it from the blood, and when we look at it, there's no virus that we can detect. Even though you still have the virus in your body, there's not enough of it that we can detect, right? And we saw very few cases of HIV occurred. But when they looked carefully at why they occurred, it had to do with whether the person was on the right drugs and if they were even taking the drugs the way they said they should be. So this ended up in the seminal study, the most pivotal study that underlies this research, the partner study, where it looked at the risk of HIV transmission in heterosexual and gay mixed status couples, in which the partner living with HIV took HIV treatment and had that undetectable viral load. The 2016 results showed that after more than 58,000 instances of sex among over 1,000 couples who were not using condoms, there were zero cases of HIV acquisition within the couples. None from anal sex, none from vaginal sex, none from men to women or vice versa, or in two couples of the same sex. Nada, nothing. This is a huge deal. Understand that those data and those images that I was showing you back from the 80s, these people were told they were a living death sentence. They were made to believe that anyone they even came into contact with, let alone had sex with, and God forbid without a condom, right? They would cause that person to die. Now, it's important that I qualify this zero risk of HIV transmission. There's certain conditions, right? You heard me say it in both of the studies. It has to be a person taking their antiretroviral therapy every day. That person's viral load has to have been undetectable for at least 6 months, and then it needs to remain undetectable. But with those 3 conditions in place, people living with HIV can lead normal lives, healthy sexual lives, loving relationships. These are folks that are having families, having children who don't have HIV, who are living to be old. I have a tradition in my clinic. We celebrate. We celebrate the first day you meet me. I mean, because come on, no. We celebrate because you were strong enough to come and get care. Then we celebrate when you start taking your meds. Man, but it's that 8 weeks, because the science shows that 8 weeks from whatever time you start taking your medicines, if you've been taking them every day, that you'll be undetectable for the first time. That's one of the biggest celebrations in my clinic. Pre-COVID, hugs. Well, only if they wanted the hugs. I can't force my hugs on people. Post-COVID, air hugs. We do a lot of this. And there's a lot of laughing and a lot of celebration. But it's that 6 month, man. That 6 month in my clinic, whew, we get down. Because it's a big deal. That death sentence, that ignorance, that stigma, that lack of information, it's off their back. They can go and lead these healthy lives, knowing, and I remind them every time they're in my clinic, you're gonna die of old age. You're not gonna die from HIV because you take your meds every day and you've been undetectable. You're gonna die of old age. Why do you need to see me? Because of all of the other things we know can happen at higher risk with people living with HIV. That's why they see me, so I can make sure that they stay healthy. But if they take that one pill once a day for the rest of their lives, they'll die from old age. And that's a beautiful thing to be able to say from where we were in 1982. So these are some of the images that accompany the U=U campaign. At the top left, I won't transmit HIV to anyone. We were able to change that to I can't, as long as I keep those 3 things in mind, right? I became untransmittable. HIV medication makes the virus undetectable, and undetectable means it can't be transmitted. I'm not HIV, I'm just me. And this quote that I love from this campaign, for too long we've put up with people's opinions about HIV and people like me, but now we have facts. This is not an opinion, it's science. And that is why the U equals U campaign is one that I feel strongly about, that I speak at it any time I'm given the opportunity, and I think is so important for you to understand as you start to consider how we can move forward in having a more inclusive, a more understanding, and a way to embrace this community, just like we would anyone else. And so that we can get these numbers to the levels we need to. Those bar graphs I was showing you where the orange suddenly dipped down, right? We can get those all high across the board. 90% of people who get tested know that they're HIV positive. And then 90% of those people have a doctor that they have access to. And then 90% of those people are taking their meds every day and able to stay suppressed. That is my hope. That is what I work hard for. That is what the likes of Dr. Eccles and the city departments of health dedicate their time and energy and resources to, because we can get there, but we've got to break down some of these walls. So how can you help? Well, number one, educate yourself. You can check that one off the box. You signed up on a freaking Wednesday night to listen to the likes of me and educate yourself. So you've already done one of these, right? But then you got to start talking about it. Talk about what you've learned, right? Have these conversations in your family, with your friends, with loved ones. Break down the stigma and the ignorance. Be a change agent. Reach out to me. Reach out to the city. We keep information on our websites. I'm happy to arm you with that so that you can have these conversations and have data. What I love about being a scientist is I don't just argue to argue, man. If we're gonna talk COVID, I come with facts. If we're gonna talk about people living with HIV, I come with facts. If we're gonna talk about basketball, facts all day long, right? You wanna back up your talk. You don't wanna see me at a spades table, boy, because as you can tell, I talk in my job, but I talk at the spades table too. But if you can back it up, then you can get somewhere. And then the last thing is take action. The great Dr. Martin Luther King said, it is not enough to be compassionate. You must act. So stand up to stigma. Talk openly about HIV and stigma. Choose supportive language that is not stigmatizing. Speak out to correct these myths and stereotypes, and then educate yourselves and others. But it's not easy. And there's people like myself, like Dr. Eccles, who've dedicated our lives to empowering people and getting the tools out there and the resources to move forward. So if you're here tonight and you are part of a community organization, a church, any position of leadership, and you want to be a part of the change, then let's partner. Let's talk about how we can move forward with this information. Because I assure you, most people above 30 to 40 years old who haven't stayed current, they remember the 1980s and the 1990s. And can you imagine if those are the types of conversation they're having around people living with HIV? That's wrong. Because the data I've come to is different. It's empowering. 1 pill a day. U equals U. This is where we are now in 2020. And we cannot go backwards. So let's do these things. Let's move forward. And let's pave a path towards inclusivity so that we can get to these 90-90-90 goals. Thank you so much for your time.
Dr. Mahdi, thank you so much for that powerful presentation. We do have a few questions in the chat. Before we go to the questions in the chat, one of the challenges that we've seen on the public health front is providers who don't necessarily either buy into the U equals U campaign, or they have their own stigma and bias about people who are living with HIV. What advice would you have for medical providers who struggle with their own bias, which impacts their ability to provide quality care for individuals living with HIV?
That's such an excellent question, Dr. Eccles, and thank you for raising that. You know, I'm also on the leadership, I think I presented that earlier, of diversity and of the D&I office of diversity and inclusion at Washington University. And the one thing I've learned through my time there and through training is that we are all susceptible to implicit bias. Implicit bias means unconsciously, right? We entertain these wrong beliefs. They're wrong, but it's unconscious. it's stereotypes, it's attitudes, it's habits that then form, right? And so as much as I preach this, I have my own implicit biases that I bring to the clinic just by virtue of who I am and where I was raised. You do, Dr. Eccles, right? Everyone on this call has their own implicit biases. And the only thing that differentiates one person from another is the willingness to face that, right? To learn about it so that you can see it earlier, and then to look for the tools to get past that. So for me, it's checks and balances. I keep my ego in check. I worked really hard to be a physician. And we all know, right? If you're a doctor in this country, a lawyer, an accountant, you walk around like you the bee's knees. But I learned very quickly that I need to have a team, and that team keeps me balanced. And I'll tell you what my team looks like. When I treat someone living with HIV, I introduce them to a social worker or a case manager who brings incredible resources and has a lens that I don't have. I can't see 360 degrees, right? So while I'm looking this way, the case managers are covering this side. Then I have health behavior coaches, people who live with HIV that bring that experience and support, right? We have psychologists and counselors that round out that 360 degrees. So one of the things I would say is to reach out to people who have expertise in this area that can support you. Infectious diseases specialists being top of that. This is what we do, what we're trained for, what we're passionate about, right? What we dedicated our lives to amongst other infectious diseases, but HIV being very high amongst those. We can help you. We can answer questions, consult us, email us, reach out. My email address is right there on this slide, right? You now have another resource and another arsenal in your tool pocket. But other than that, you have social workers, case managers, so many resources at the city, county, state departments of health, right? That you can access. And so I would say, make yourself not a one-man army. Increase that team for the betterment of your patients. I am a better physician because I do not stand alone. I have folks that empower me. And even to this day, I have mentors that I go to when I have difficult cases, when I'm struggling, or when I think I haven't done right by a patient. I tend to get really good feedback from my patients. I got humbled the other day. It was 2 weeks ago, and a patient was not happy with me at the end of the visit. She said, I made her feel uncomfortable. I used language that was triggering. And I could have used my ego. I could have said, that ain't me, and most people love the kind of doctor I am, and you can go see someone else. But I apologized in that moment, because whether or not I agreed, something I did was wrong. And I had to reflect. I had to leave that office after apologizing and hearing her. And I had to humbly, it was hard for me, but offer her another provider if I needed to. And the victory there was, she said that it was my humility and my apology. She called back after the fact and said, listen, I was having a bad day. Please tell her I didn't mean anything by it. I'd still like to see her. But I know I would have lost her if I had come at her with a different attitude. But the other thing I did was I reached out to a mentor. I reached out to someone who is even more seasoned than I am. And I said, can I just talk to you about this case? And we talked through it. And they gave me their expertise. This is something physicians should be doing all the time. We should be physician scientists, meaning we should be looking at the data and reading it and staying up to date with the most up-to-date facts and figures and treatments, right? But we should also be humble enough to be constantly trying to learn and improve through mentorship and through team-centered approaches.
Great, thank you for that. We'll start with the questions now. So the first question we have is, how does Missouri's rates for linkage to care and viral suppression compare to other U.S. states? And so I'll take that one if you. Okay, so in 2017, according to the data that was published by the CDC, the state of Missouri ranked 24th for viral suppression. At that time, 64% of persons living with HIV in the state of Missouri had achieved viral suppression. However, the goal for the United States at that time was 80%. And so there's still a lot of work that we have to do across the state of Missouri. But as a fast track city, the city of St. Louis has dedicated itself to achieving 90% viral suppression for the individuals living with HIV. And so one of the challenges with that is, one, we have to hold ourselves accountable, but we also have to really do a better job of engaging the community that we're charged to serve and protect. And so over the upcoming months, we'll be issuing additional information about fast track cities and what that actually means, not only for the health department, but for the community at large, because again, this is a team effort. We cannot, the health department can't do it alone. WashU can't do it alone. Physicians can't do it alone. We have to work, the entire system has to work together in order for us to achieve these targets. And so that's what we're aiming to do. And today is one of the steps that we're taking to make that happen.
Absolutely. And I will just say, I'm one of the co-chairs of the Fast Track City St. Louis initiative. My co-chair, Fernanda Thomas, is on this call. We have dedicated ourselves to bringing together the leading community partners, including Vivint Health, Williams and Associates, and then the city and county Department of Health, and the mayor has supported us tremendously here in signing the Fast Track Cities Agreement, which means we want to reach those 90-90 goals, 90-90-90 goals that I showed you earlier in the slide, where we want to be able to say that 90% of people have been able to get tests and know their status. 90% of those have been able to be to link to care, right? And then of those 90%, we have seen viral suppression. And so that is something that we're working towards. Our 1-year anniversary comes up on December 1st. We have some exciting things that we will be sharing with you about the work we've been doing, data that we can bring to you, and then regional services that we want to be able to then bring by way. But our website will be launched and our Twitter account will be launched on December 1st. So there'll be more information there. So if you're looking again for a partner, leaders, all the leaders that sit at the table around this, to help your organization move forward your work as you want to dismantle the stigma and increase the quality of care for people living with HIV, please reach out to us, and I will ask that Dr. Eccles be able to forward that information to you after this evening.
Absolutely. The next question is about the data. And so then in the data that was presented regarding the linkage to care and diagnosis, HIV related diagnoses, the question is, what about transgender data? Is that available?
That's an excellent question. Unfortunately, we haven't seen as stringent data across for our transgender community at the state level. Across the US, though, we do have numbers there that the CDC does show. So if you go to cdc.gov into the statistics corner of HIV, they will provide that data. But again, unfortunately, we are getting more and more of that data as time goes on. It was difficult for us to get that in a standardized way across all 50 states.
Great. The next question is from an anonymous attendee. The question is, I have a question about the colors that are being displayed in your chart. What does the color represent? Is this cascade for 90-90-90?
Yes, excellent question. That was the HIV cascade. When we talk about the HIV cascade, we talk about 3 groupings, right? Number 1, people who are tested so that they know their status. Number 2, those that are linked to care, meaning they can find a physician to help address their diagnosis. And then the third part of the cascade is those taking their medications, how much of them are taking that such that it's working, that they're suppressed, meaning they have undetectable virus in their blood. Those are the 3 aspects of the cascade, and that is what those colors were trying to represent. And so that's why we're saying we want to get to the 90-90-90 goals, where it's 90% for each of those 3 categories.
Great. The next question is from a health department employee. So we're excited that our staff are tuned in tonight. And the question is, how often should patients be tested for viral load suppression after starting antiretroviral treatment?
That's an excellent question. It varies. So we do it a little bit more frequently in the beginning to make sure that the meds are working. So typically what happens is someone comes to see me right away, and the data now shows that you should never delay starting medications unless there are very few times that you should be consulting with an infectious diseases specialist like myself, where you don't start it right away. There are some instances where that doesn't happen, but it's very rarely. Most people should be started right away. And it takes 8 weeks from the time, approximately 8 weeks, the research has shown, from the time that you start taking your meds to reaching that undetectable status after 8 weeks. And so we will typically check a viral load on that first day. Some people will check 4 to 6 weeks, but not more than 8 weeks after that. And then in the beginning, you want to see people more frequently as you're building a relationship and a rapport. Make sure that they're doing okay with their medicines, but you will be checking then that viral load every 2 to 3 months typically. And once someone has been suppressed for a long period of time, they have to have a viral load at least twice a year, but most people are doing that every 4 to 6 months.
Just to piggyback on that question, so we talked about providers before. So one of the things that happened in the 90s and early 2000s was that primary care physicians didn't feel it was within their wheelhouse to provide care for individuals living with HIV because they felt it was more for the specialists. So can you talk about how that has evolved? So now that primary care physicians can actually monitor and provide quality care for individuals living with HIV.
Absolutely. I believe that a physician who's dedicated their lives to taking care of folks in the primary care settings should be empowered to take care of people living with HIV, but there are caveats, right? There are times when folks come with very resistant virus or have very complex issues. So I always say that if you haven't had, infectious diseases specific training around this, that you should always know that you should know before you start the care of people living with HIV, who you can go to for that increased help, who you can consult, where you can send those patients. And I would also encourage you, just like I would for any specialty, right? Stay current, stay up to date. We provide through the state, through the city and the county, and certainly through our academic institutions, training. I provide some of that training to NPs and nurses in the past during my fellowship around sexually transmitted infections and HIV. And you should be trained if you're going to do this and continue to stay current throughout your time. This is the only, I have to do this infectious diseases. Anyone who's taking care of these patients should. But I would say that if you don't have infectious diseases fellowship training, that one thing that I would say is that you make sure you know who you can go to if you need help with some of the more difficult cases. But past that, I love working with our family doctors, our primary care physicians, and folks and nurse practitioners who have become such a pivotal part of the care that we provide for people living with HIV. We're all in this together and can all provide exceptional care.
We have a few more questions, and we're limited on time, but we're going to try to get through all of them. The next question is, what are the contributing factors for the issue of discontinuity of care?
Thank you so much for this very important question. And it's something I started to talk about, but because I wanted to stick to stigma predominantly, I don't think I flushed this out. But the social determinants of health, the things that make it difficult for people to access care, are really what I see as being barriers. And these are things like transport, right? People who don't have access to reliable transport to get to and from. You can think it's easy to just say, here's a bus pass, but do you know what it's like in the middle of winter to wait for a bus, that bus to be late, right? To have so many other things that may get in your way. Maybe you have a bad hip or a bad knee, and that's really hard for you to access, right? Your living situation, not having regular childcare, working jobs that don't really gel with the sort of 8 to 5 that, clinics often are open on, and maybe not on the weekends, unstable financial support, and basically people who live very real lives that don't have the privilege and the luxury that I do every day, right? And who have to worry about 5 or 6 different things before they even get to their healthcare. It is my role as a physician who has access, thankfully, to these amazing institutions, to use those institutions to try to remove those barriers. And that's why I say that when I practice this care, I do so with a team. My case managers are as important to the patient as I am, period. My health behavior coaches, I feel the same. My nurses, my psychologists and counselors and psychiatrists, without them, undetectable doesn't happen. And undetectable doesn't stay. And so I really do believe that those social determinants of health is what I spend the bulk of my time really flushing through. We see a very large aspect of mental health that is accompanied by this. So many of my patients will tell me, Doc, just coming to the clinic triggers me. Just taking that pill reminds me of my status, reminds me of how I'm treated different and how I'm isolated and shamed. So that's why I don't take the med. Or Doc, I can't get out of bed most mornings. I'm so depressed. I'm so anxious. Doc, I have kids. I have a sick parent. I take care of my mama and my grandma. Doc, I am suffering with addiction. It's real for me. And I'm not interested in going to rehab. It's never worked, right? But I have so many other problems before we even get to this diagnosis, before we even get to this medication. Those are the types of barriers that prevent people from being able to take a pill a day consistently. Because understand, folks, that HIV is not forgiving. The reason why it's one of the most difficult to manage diagnoses is because, unlike some other illnesses where if you skip a day or two or even a week of your meds, you're going to be okay. You skip even a day or two, a couple of days of medicines with HIV, and you have virus in your blood right away. And it takes us another 8 weeks to get back to that undetectable. So it requires a commitment that needs for you to be at a place where you can focus on your health and where you don't have all these other mental and physical barriers to prevent you from doing so.
Great. That leads us to our next question. Where does mental health come into play?
So like I said, mental health is a big comorbidity for me. I would say that a very significant proportion of the people that I treat are dealing with some aspect of mental health. And let's just keep it real for a second. As are most of us, right? As are most people. And I will speak right now to my community, and I can speak to, my intersectionality covers a few things. I'm a woman, I'm a Black woman, proudly so, and I'm a Zimbabwean woman too. And in all of the different cultures that I represent, mental health is not easily accepted. In my country, we don't even have a word for depression or anxiety in my native tongue. When I moved here, I saw similar barriers in the African American community in dealing with mental health, and in doing so in a way that doesn't, again, stigmatize and shame people. But I think this is true across the board. I think we struggle across the board to see mental health and to address it effectively and in a timely fashion. And that plays a huge role in what I see. But again, it's that internalized stigma, I'm going to keep coming back to this, that drives those issues with mental health too. And if we remove, just removing internalized stigma, just me and you taking responsibility for the role we play in making people uncomfortable with being their whole selves and speaking their whole truths, we would go a long way into it. But there's other aspects of this, in that mental health services are very, very difficult to access. We have long waiting times. We are oftentimes under-resourced. These are people who dedicate their lives to this, but we do not have enough. So there's a pipeline issue where we need more providers, physicians, nurse practitioners, psychologists. We need a better system that's able to plug people in. As quickly as we're able to get people in for medicines, we should have that same linkage to care for mental health, and that doesn't always happen. Some of my patients have extraordinarily long waiting periods.
Great. The next question is, some providers and patients do not buy into U equals U because the thought that that it represents non-adherence to medications. What is the best way to approach to change this thought?
I should have said this in my presentation, so I appreciate having such active and smart attendees tonight, because you're really rounding out my presentation and making me look better than I really am. But one of the issues that I didn't get to is that when you have a campaign like U equals U, understand that came 15 years into knowing about this disease. So understand how deeply embedded the culture was in being dedicated to the stigma and this shame and making people feel like they were a walking, talking death sentence, right? So just because we have this data, we have to understand that it takes a while to shift the culture, and that there's going to be barriers to that, because no matter how much you tell even the most educated person, right, if they're holding on to what they saw and what they believed and what they read for 15 years with images and negative stereotypes, it takes a while to break that down. And so it takes dedication. It takes the leadership of the likes of Dr. Eccles, who would say, in the middle of a pandemic, we're going to have this talk. Because what he understands as a leader is Just because COVID is upon us, everything else doesn't cease to exist. And what he knows, because he sees the data, is that people living with HIV have been having some really tough statistics during this pandemic because of difficulty accessing care, because of, again, those social determinants of health that made the telehealth, portion of what we were doing not feasible for some. And because, again, it was another stressor that maybe took precedence over people taking care of their underlying conditions.
The next question is, it's anecdotal, but have you noticed stigma more in people who grew up in the 80s and 90s with the fearful messages about HIV, or is it across all ages fairly evenly?
Man, these are some good questions. We got to keep doing this, Dr. Eccles. I like this. This keeps me sharp. But, that's such a good question. And I think about this often. And what I really think I've come to now is that it's different. It's different in that you see it across the board, but you see it in different ways. And I'll tell you how. The older folks who've lived with this and saw this before are just quiet with it, but they're convinced. And a lot of times there's no changing their minds, and it's very deeply embedded. But in the younger generation, I see something very sad, though, where, again, for many of my patients, I would say at least a third to a quarter of my patients, I'm the only person who knows about their diagnosis. And this is across the board. This is in young folks and in older folks. And in the younger folks, it's because of this really horrible stigma and very, very nasty behaviors around shaming folks that happens. And so they're afraid to date. They're afraid to have healthy sex lives. They don't think they can have kids. They live in fear. And so I see it in different ways, and I see it manifest with different types of questions, but it's certainly, I see it to some degree, a little bit more, definitely more in the older population, but to some degree in all of them.
The next good question is, why do you think Black people are disproportionately affected, and what do we need to do differently to reverse that fact?
The same reason we're disproportionately affected for about 10 to 15 other reasons, right? This goes back to history. This goes back to slavery in this country. Systemic racism, institutional racism that has caused disparities in health, and a deep distrust in our community for both government and medical communities, because they have failed us, because of Tuskegee, because of slaves being used as guinea pigs without even dignity or respect or consent, a lot of times without even pain medications being cut through, right? Because of the Henrietta Lacks, whose cells we use to this day in the name of science, that were taken from her without her consent, without her family's consent, without even giving them any measure of payment. Tuskegee, the abomination that was Tuskegee. And those are just the ones you know of. There are many more that have happened. That happened to our children in institutions, to our family members in hospitals, right? And it took this year and an uprising for us to start to talk about it. So there are disparities that exist, and there is mistrust in the Black community for very real reasons. And it is the work of people like myself, Dr. Eccles, and other government institutions, but also academic institutions across the country that pride themselves in being the best of the best, need to acknowledge their role in this historically and presently, need to apologize for it, and need to start to show actual plans as to how they are going to address this. And those plans can no longer be lip service. They need to be backed up with actual funding, and that comes from the top level of leadership. I am encouraged by President-elect Biden and Vice President-elect Harris and their 4 pillars that they produced for their administration plan that included racial equity. I will believe it when I see it, but I haven't seen it for quite some time. And if that is true, that is finally people saying that these communities have reasons to have these disproportionate numbers. So I think it's a combination of the biases that have come from institutions and through that systemic racism, and the Black community themselves having this mistrust, right? And all of the socioeconomic issues that have arisen historically that mean that their social determinants of health list is a longer, harder list to overcome for them being able to access healthcare and be healthy themselves compared to other groups. I will say that that is an opinion. I believe that my opinions are based in a lot of fact that I'm happy to share data for, but I cannot, I'm speaking for myself here.
I'll just add on a little bit to that. So one of the challenges that typically in government agencies, the government agencies can oftentimes perpetuate these issues that impact and result in disparate health outcomes. And so part of my charge is being able to make sure that the City of St. Louis Department of Health holds itself accountable for doing its own work, meaning understanding the system so that we don't perpetuate those same issues that we talk about day in and day out. So health equity, social injustice, health injustice. We can all, if we don't do our work, we can perpetuate that. And so when we understand the system, we understand how it works and how we can intercept and change the trajectory for a lot of these issues that we talk about monthly, annually, biannually in our community. The next question is, will Missouri Department of Health work with all HIV providers on developing protocols for rapid start and accountability for improving the 90-90-90? And so I'll take that one. So the City of St. Louis Department of Health, we work really closely with the Missouri Department of Health and Senior Services. This is something that that's on their radar as well. However, the only fast track cities in the state of Missouri are the City of St. Louis and St. Louis County. But we really rely on a lot of the work and resources that are available through the state. Again, we know that this is a priority for the state as they are dedicated to ending the HIV epidemic. And so one of the things that we can bring to their attention is the need for additional training and resources for HIV service providers. Next question for you, Dr. Mahdi, is, does the Missouri Department of Health and Senior Services have short-term goals like other cities, 90-90-90 by 2025? Also, the new target is 95-95-95 by 2030.
So the Fast Track Cities initiative is a partnership that I'm co-chairing between the city and the county departments of health, signed off by the mayor and the county department of health, the city department of health, that brings to the table all the major HIV community partnerships and organizations, as well as leading experts as well. They are dedicated to reaching those goals. You're absolutely correct. The new target is 95-95-95, and I'd like to see us reach that. But at the time of its inception, the Fast Track Cities initiative, which is now, I think, 3 years or so in the making, was 90-90-90. So while it's been updated, the paperwork officially still says 90-90-90. And so that is where it's at. But you're absolutely correct and very well informed.
All right, and we're at our last two questions. So the next question is, so if we can get a vaccine for COVID in less than a year, why can't we get a lifetime or annual pill, or better yet, a vaccine? Is it because of the complexity of the virus, or because of the stigma and lack of government interest to support with the funding needed to achieve satisfactory resolution?
It's a great question. So a couple of things go into play. We've been trying to develop vaccines for HIV for many years, since the beginning. And it's very difficult for the reason that you brought up, the fact that this virus replicates at such a high magnitude. We're talking in the order of hundreds of thousands of times in minutes. And so that makes it very difficult to come up with an effective vaccine against it. So those vaccine efforts are ongoing. That's very different from other viruses like the flu vaccine and now the COVID vaccine that we're able to come up with vaccine targets for. But you're absolutely right that some of the other barriers and some of the other issues around, competing agendas and funding and things of that nature also make it difficult. But to the credit of our government, there has been great attention paid to funding for HIV research in general and certainly in vaccine development. And I have to give a lot of credit to St. Louis University, that are one of the leading institutions in the country for vaccine development in general. And we have other basic and translational researchers, both at St. Louis University and Washington University, who work on these.
And then our last question for this evening is it safe? Well, and I think if you can talk a little about risk reduction as part of this response. So it says, is it safe to have sex with an HIV positive person if they're using medication?
So again, this is the basis of the U equals U campaign that I talked about earlier. The undetectable equals untransmissible, but there were 3 caveats there, right? You had to be taking your medicines on a daily basis. You had to be undetectable for 6 months because you'd been taking your medicine. With that in mind, then the people who have achieved that undetectable rate for 6 months are taking their medicines, 1 pill a day, and then who stay undetectable after that can have sex without a condom, and there has been data to show that they cannot transmit it to anyone else. And we've seen this in thousands and thousands of couples where one had HIV, one did not, and they were having sex without a condom. Again, though, there are those 3 caveats. Taking your medicine, 1 pill a day, every day. 6 months, you've reached the 6-month mark at least of being undetectable, and then you've continued to be undetectable past that. And I work with people who are in relationships, and I tell them, bring your partners to clinic. We can talk about it. You can show them, the data. But at the end of the day, this obviously has to happen as it does in any other situation, in a trusting relationship where you have access to this information and you're willing to be honest between the 2 of you. But at the end of the day, everybody has to be consenting and comfortable. I can only tell you this information. You still have to do what you think is best for you, but that is the data. And then how do you know if the medicine is effective? Well, we, again, test people's blood. They see me depending on where they are in their journey, either every couple of months or up to every 4 to 6 months. And we measure it in their blood to be able to tell if they're detectable or not. So this is one of those areas where a blood test can tell me. So if someone says to me, I'm taking my meds every day, doc, they can lie or they can be telling the truth. I can tell just by drawing their blood. And that's how we know the medicine is effective, is that we test their blood for it.
Excellent. So Dr. Mahdi, thank you so much for gracing us with your presence and sharing your expertise with the health department and its partners and stakeholders across the city of St. Louis and the St. Louis region. We're grateful that you are a champion for public health and you're on the front lines with us fighting this great fight. Again, thank you so much for your time. Thank you to everyone who took time out of their busy schedules to tune in to learn more about HIV and AIDS and to get factual information. We know that there's a lot of misinformation circulating in our community that is causing harm to our most vulnerable populations. And our goal, again, as the City of St. Louis Department of Health, is to make sure everyone in our city and in our region has access to accurate information so that they can make informed decisions about their health. Again, thank you so much and be well.
Thank you.